So here you are watching Coblation intracapsular tonsillectomy in a 34-year-old male with history of obstructive symptoms. We are going to perform septoplasty, turnoplasty, adenoidectomy as well. But I'm starting with tonsillectomy because his tonsils are also pretty large and he has a difficulty sleeping on his back. He sleeps with his mouth open, and obviously enlarged tonsils are also one of the reasons for that. Though he does not have frank obstructive apnea, sleep apnea. So now you can see I am melting down the lymphoid tissues at a setting of 9 for ablation and 4 for coagulation. So I'll use coagulation to the least. Most of the times I'll be using only ablation. So you can see he's got a long uvula, but I'm not going to do a uvulopalatopharyngoplasty because his major complaints is in the nose, and I'll take care of that. So to prevent the uvula from coming in the way, what we could have done is to use a rubber catheter to keep the uvula away, which I'll do if needed. But at this point of time, I'm only concentrating on intracapsular reduction of the lymphoid tissue, which will be a painless and bloodless process. Why? Because I'm not going to expose the muscles and I'm not going to expose the vessels. You can see that's the pillar. I'm only going to stay in the lymphoid tissues, and the aim is to remove 90-95% of the lymphoid tissues and not 100%. Because the moment you try to remove 100%, you will go and hit the vessels and they can bleed later on. If you do not, then the chances of the post-operative bleed becomes absolutely minimal. And he has to travel to another country, I think US, in the next 10-12 days. So I will make sure that there's no problem in traveling and there's no question of bleeding while he's not here. So this is still the lymphoid tissue, and you could just saw that muscle twitch. That means I was close to the muscle. When you see the muscle twitches happening, that means you are already reaching the limits. And our aim here is to give him a breathing benefit. His tonsils were not recurrently getting infected. He did not have fever. He did not have any severe throat pain issues. So removal of 100% of tissues is anyway not necessary. And but at the same time, if you do not remove most of the tissues, then the surgery remains incomplete, and then you may get a recurrence or a problem again. So we will make sure that we do not leave behind too much of lymphoid tissues. We'll only leave the last layer. So you can see I'm going inside layer by layer. And as we reach near the fascia, we'll stop. Alright. So I'll still make sure that I am not leaving behind any significant lymphoid tissues. That's the lower pole. And you see I have already reached the fascia at the lower pole. There is still a little bit of tissue left at the posterior pillar. Alright. Now, before I come to the superior pole, which is here, let me see if this soft palate or the uvula will come in the way. So I'll take a rubber catheter and insert it through the nostril. Let it come down in the oropharynx and just gently use it to elevate the uvula so that it does not get pulled in the coblation. And now we'll go to the superior pole and see how much tissue was still there in the superior pole. Layer by layer removal of all the lymphoid tissues till the fascia is reached. Can you see the fascia here? That's the fascia. So I will just reach the fascia and not open up the fascia. This is the lymphoid tissue. Obviously, I do not want to leave. You can see a stone over there, tonsillar lith. Alright, so that's the fascia. Another stone, the tonsillar lith. That's the superior pole. You could see some more stones coming out. Alright, so again, layer by layer removal till we have reached the fascia. That's the fascia, very, very clearly seen. And we still have this lymphoid tissue here. That's the posterior pillar, and there is some lymphoid tissue on the posterior pillar. So I am gently removing the tissues on the posterior pillar, because if I leave lymphoid tissues behind, then they will come back to haunt, which obviously we do not want. We want to do as clean work as possible. Now, being very careful not to damage the posterior pillar, but to remove all the lymphoid tissue. And the last layer of lymphoid tissue can be coagulated. So see, that's the fascia. This is all lymphoid tissue. Wherever I am not very comfortable ablating, I will go for coagulation. So far, I am able to ablate comfortably. Now, I am very happy that I have not left behind any significant amount of lymphoid tissue. in the superior pole. There is a little bit of lymphoid tissue on the anterior pillar, which I am ablating. And this is the last layer of the lymphoid tissues, which I was unable to see because of the anterior pillar lymphoid tissue here. Now, that's the last part. Here, the tonsil always goes a little deeper. And just below that, you get the tonsillar artery. So, I do not want to open up the tonsillar artery. At the same time, I do not want to leave any significant amount of lymphoid tissue. Now, I am happy. I have reached the limit everywhere. There is no significant amount of lymphoid tissue. At the same time, there is no exposure of the muscle. And so this surgery is going to be painless and bloodless. Thank you for watching. चलिए इसको